For the next half an hour or so, I'm going to talk to you about the difficult decision around retirement in concussion in sport. There's my declaration of interest. As Louis said, I work for teams, work for the Institute of Sport and the Olympic programme in Scotland, but I also work for the Scottish Government. And obviously it's a big year for Qatar with the World Cup. I was fortunate enough to be involved in the World Cup in Russia with a team mainly around decision making around head injury on the background of things like the Karius goalkeeper incident, where a high profile player made a mistake in a Champions League match and then subsequently claimed that he had a concussion that hadn't been picked up. So from my World Cup football perspective, I was trying to develop systems so that would be less likely to happen to the team that I was involved in, that we would pick up any concussions that happened and be able to change them for a player that was more able due to head injury, obviously. And finally there, I am on the immediate care advisory group for World Rugby, that we develop and run all the training and emergency courses available for all rugby nations in the world for player welfare. Briefly, just to touch on it, Louis mentioned it, in Scotland we have a single policy for all sports, so it doesn't matter if you play hockey, ice hockey, netball. The guidance is exactly the same for all athletes in terms of how it's managed and time away, and we're very fortunate that that's government backed with all major sports on board. It's handy being a small nation for that. We've reinvented our advice on 3 occasions now. Most recently is just happening. Obviously we're aligned with the Concussion in Sport Group advice, but each time we've reinvented, there's been a different focus. The first time was just about trying to get the government on board in a single policy. This photograph is from the second, or the first reinvention, if you like, the second version of the guidance, where we really wanted athletes to be front and centre. So we got some high profile athletes involved in the campaign, right across from Paralympic sport to professional football and all the other sports across, even the strange sport you might not have heard of, a Scottish sport called shinty, which is a bit like hockey, but it's played like full contact golf. So interestingly, sorry, let's go back to that last one. The third iteration of our guidance was talking about, which we're doing just now, is certainly in Scotland, nobody really knows anything about concussion, certainly healthcare wise. Nobody's had any undergraduate education. Doesn't matter what background you're in, whether it's medicine, nursing, sports science. There's very little undergraduate teaching on modern concussion management, and yet it's such a high profile, prominent topic in all forms of sport. So similarly on a postgraduate level, so we really see it as important to do things like this to try and share knowledge and try and improve our knowledge of concussion, even on our own doorstep, let alone around the world. And that's similar when you look at the science of concussion. Just was saying that the undergraduate and postgraduate education, there's so many strong human stories about concussion and poor outcomes, which are really tragic. But when we're coming through medical school or whatever, or university, we learn about levels of evidence, and everybody's thinking about meta-analysis, systematic reviews, double-blind randomized trials, prospective studies as being the sort of evidence that you want. And that's me speaking as a clinician, not a postdoc scientist. All clinicians have got an interest in science, but I'm certainly not. I wouldn't say I'm a PhD scientist. And most of the stuff that we have on concussion isn't like that. It's not double-blind randomized trials. The best evidence that we have, unfortunately, still remains retrospective studies or small prospective cohort studies, simply because when we're trying to make decisions on the playing population just now, the young population who may be struggling with concussion, we haven't got time to wait 30 years to follow these groups through to find out, are they going to develop long-term neurodegenerative problems? So we have to design science in different ways to try and find the evidence. And I've picked out sort of 3 landmark papers from my experience. relevant to sport, relevant to the general population, and then relevant to the topic of neurodegenerative disease. I'm just getting a bit of feedback there.
Please mute all your microphones.
The first study is relevant to professional football, and that's the study on the left there, the table on the left, the field study, which is a Scottish study from Glasgow University, and they looked at retrospective health records and death certificates of professional footballers in England and Scotland. And the bottom line for their retrospective study was they found that you were 3 to 4 times more likely to die of a neurodegenerative disease if you were a professional footballer who played in the 1960s, 1970s, 1980s in the UK, as opposed to the general population. Interestingly, that study, a lot of the messaging around that has been extrapolated a bit to sort of talk about heading and say, oh, well, it's from heading the football. But actually, they didn't look at that. And with it being a retrospective study, that's an assumption. But interestingly, they did find that goalkeepers, who obviously don't do anywhere near as much heading, had a lower incidence or lower hazard ratio of 1.8 as opposed to the 3.6 or 3.8 from the outfield players. But it doesn't, they didn't look at heading, and the design of the study means they can't say that, but it's interesting nonetheless, and that's the most relevant for us in Scotland, where we think about, well, we should be conservative in our guidance just in case until we know more. The middle studies is a prospective study, and it's a larger sample size, but it's in the general public, and it basically just followed people through who've had a traumatic brain injury, not just sporting concussion, but through the emergency department, followed a much larger sample size through prospectively for 10 years, and again found a strong association. I think it was already known that traumatic brain injury does increase your risk of neurodegenerative disease when you get older. Similarly, to flip the coin, because if you listen to a lot of the messaging at the moment, it's easy, certainly through media and social media, to assume that that's a really strong association. But if you look at the table on the right, came from the Lancet Commission, the journal The Lancet, on dementia that was published 2 years ago, and they listed 12 modifiable risk factors for development of dementia in our lifetime. And not surprisingly, a bit like cardiovascular risk factors, the brain being such a vascular organ, a lot of those are things like diabetes, hypertension, smoking, but equally there's a lot of psychological and social factors around social isolation, depression, physical inactivity, which is an important one as well. When you're having that conversation with the general public, we know that physical activity is the best thing you can do for your health, and yet there's a lot of negative messaging there about sport and the risk of head injury and neurodegenerative. But for the vast majority of people, physical activity is protective against dementia. So I've touched on the human aspect of concussion and how prevalent it is at the moment. And truly, when you hear these stories, they really are tragic, of young people or people who've devoted a lot of their time to sport and to entertainment in some aspects, now struggling with some form of neurodegenerative issue, whether it's memory problems, a diagnosis of early onset dementia, or in some cases post-mortem diagnosis of CTE. They really are tragic stories, and that human side of concussion really steps forward away from the protocol-driven return to play that we're all involved in week-to-week sport. The narrative changes from when can I play next, doc, because I've had a bit of a headache after a knock on the head. It's probably going to be in a week or two, right up to people who, once they start struggling and finding concussion difficult, that human side steps forward and becomes very significant for them, for us, and for the media. And one of the challenges around having conversations of when is too much is trying to manage this human side of concussion and the emotional, that we're actually trying to estimate risk of long-term problems is very difficult because the science isn't there. And I put the Twitter emblem there. Obviously, social media plays a large part in promoting these sort of messages, which is good in some ways, but also challenging in other ways. Similarly, when we're thinking about the performance side of sport and concussion, there are many more people who have an interest in that particular athlete than just the athlete themselves and what they are doing. Obviously, in professional sport, coaches' careers depend upon the players they have playing for them. And again, I've yet to meet a coach who doesn't truly care about people as individuals when they're struggling. But equally, their job probably depends on having these people available for them, their best players. So their lifestyle depends on it. So there are coaches, there are agents, professional people involved in some of the decision making, and also on a human level, but also family will have concerns, and all of them will be exposed to that human messaging that we're seeing frequently now. For what is for some people, but not for most, a very financially lucrative career. But for many, they don't make a lot of money. Their glory is more about the winning and the being involved and the feeling part of a team. But as we all know, probably many of the people in this room are probably ex-athletes, whether that's amateur or even performance. It comes to an end at some point, and depends on whether the athlete's got a good plan B to go to. What are they going to do after the career? So part of the management of preparing athletes for the end of their career starts when they begin their career, because it's going to end at some point, whether it's through choice, whether it's through a musculoskeletal injury, or whether it's through concussion. What are the clubs doing? What is the sports organisations doing to give players other skills, other trades, whether it's supporting them through university degrees or helping them get on college courses to develop a skill, so that if it does all end tomorrow, what's their plan B? And having good planning around that sort of thing can help when you get to the end of career discussion around head injury, because it can reassure the family and reassure the athlete. Obviously, it doesn't do much for the coach and the agent, but these are stakeholders who will have an opinion about what's happening. Having said that, got to remember that we're doctors or we're healthcare practitioners and they're patients. So our primary relationship depends upon what the athlete wants, and not these other people, although inevitably there'll be some voice from them. And on the right of the slide there, the most important thing is to try and stay close to the athlete and try and understand what their ideas, concerns, and expectations are about the situation they're in and what they want for the long term, and try and support them to get where they want to be, if at all possible. I touched on it briefly there. There is a conflict in concussion management with the way we work. If you're working in week-to-week sport, certainly the week-to-week sport that I'm involved in, the coaches have got an idea what the team is going to be for next week already, and the week after that, because there's a kind of rotation system. So straight away, working within the concussion protocols, if somebody does get a head injury, the conversations are fairly early from the coach, from the performance team, and from the athlete about when will I be able to play again. What's my focus is getting back on the pitch for the same sort of reasons we said. They want to be involved. Being involved gives them a chance for another contract. But as soon as concussion starts to get difficult, the focus can shift for the athlete and for us, though it may not move for the sports organisation as rapidly. And then that focus is, rather than when can I play again, it's, oh my goodness, when will I wake up without a headache, or will I be able to play with my children without having symptoms? So that conflict of return to play and working with the human side is perhaps the biggest step that we need to make when discussing concussion retirement. So that ultimate threshold, yes, there are clinical factors about medicine and the diagnosis and what's going on and how much can we help. But if an athlete's goal changes from, I want to start in my football team every week and earn whatever by getting a new contract, changes to, I just want to be able to be normal around my wife, not be emotional, and play with my children, then that human side completely takes over. And that's probably the strongest message um, about concussion management in the long term, is trying to get people to support people as human beings around retirement decisions, what can often be very difficult. So the concussion in sport group, it used to be post-concussion syndrome, but the terminology now is persistent concussion symptoms. And in adults, anything more than 14 days would be called persistent concussion symptoms. In children, that would be 28 days, or under 19s, that would be 28 days. Obviously, a lot of our athletes are fairly young, certainly in the performance side, so some of those will fall into the 28 days. But I personally wouldn't be worried about someone being in and around the 28-day if they were under 19 or 14 days for persistent symptoms. Not in terms of retirement. Obviously, I'd be concerned and trying to get them better, but I wouldn't be concerned about this is the end. I'd still see that the vast majority of cases that we have who do end up being labelled as persistent concussion syndrome symptoms would be rehabable and able to be improved significantly, probably return to play as well. But when it does happen, this is the way I think about it. And the first thing is to have the conversation with the person rather than the player or the patient, just asking them, how do they feel about the situation they're in? How much do they understand? And often when you ask that question, a lot of the messaging moves very quickly to the neurodegenerative issue. Doesn't necessarily, they don't often say, oh, I'm desperate to get playing again. Some of them do, those that perhaps don't have families or a bit younger. But that human factor really walks into the room when you ask them about this. Sometimes I heard a podcast the other day by a lady called Kat Merchant, who was an England women's rugby player who did retire through difficult concussions. And the podcast she was talking about, as a physically active person, she's now a personal trainer and so still very physically active and very physically fit. But she talked about, as someone whose sport and exercise was central to her life, being told that she couldn't exercise and had to sit on an exercise bike or could only do a bit of running, was really devastating for her, and it put her anxiety up. So she was reporting persistent anxiety symptoms on all the sort of checklists and questionnaires she was being given. But actually, when you ask her, if you drill down to it, she was saying, I'm just anxious about not being able to exercise. They were trying to monitor a heart rate on exercise bikes to sort of see a heart rate variability and see what happened. But to asking her to keep her heart rate underneath 70%, etc., while she's on the bike. But she's saying that the anxiety just of not being able to exercise and wondering how it was going to go on, she felt was putting her heart rate up to that level before she even started. So that, as well as the human side, the kind of anxiety side, especially in the modern world where life is fairly stressful for everyone, and young people in particular, thinking very early on, do they need additional support? Do they need psychology involvement or pastoral involvement? We have performance lifestyle advisors in Scotland that are very close to the athletes, and that's fairly important early on to try and figure out what's going on with the person as much as the patient. Once that's happened, I tend to think about just revisiting the diagnosis. Are we sure the diagnosis is concussion? So going over the story again, looking at the symptoms and the symptom scores initially after the injury. I think it's fairly well known that if you have very high symptom scores in the first 24, 48 hours after a concussion, your risk of having persistent problems or a longer recovery is a bit higher than if you have very transient symptoms that are only a few hours. So just exploring that, revisiting the concussion history of the person, the patient. Obviously, that's particularly in the generation now who may be 35 years old, 30 to 35. Concussion reporting when they were 18, 19, 20 was very poor, and it's very inaccurate. So there will be a lot of underreporting in concussion history, but apologies, just trying to explore, how many concussions have they had, how long did they take to recover, when was the last one, what sort of symptoms did they get, what sort of treatments worked, just revisiting, have we done the right or the treatments that are most likely to help in this particular individual, given that there are a lot of physical and perhaps psychological and social modifiers of concussion and the symptoms that people experience. We know through a lot of the papers in Concussion in Sport group about the groups that have a preponderance to migraine, anxiety, ADHD, hyperactivity disorders. Have we truly picked up on these concussion modifiers, particularly anxiety and depression? Exploring those areas to see if there's anything that we can perhaps revisit and treat. I'm trying to make sure that the actual diagnosis is concussion. Like I say, that's once you've kind of looked at the patient for the concussion diagnosis, look at the treatment so far. Are we sure that we haven't actually had a missed structural injury? I've certainly got a player at the moment in an acrobatic sport who his main problem he's concerned of is difficulties with spatial awareness doing some of his complex movements, but equally he describes a numbness on the side of his face and a hypersensitivity in the periorbital region, which obviously is a little bit unusual for concussion. But we've looked at his cervical spine in terms of imaging and clinical examination. We've looked at his temporomandibular joint. He's seen an optometrist, an ophthalmologist, all trying to look for, is this truly a post-concussion phenomenon, or actually have we got a missed structural injury? Similarly, they probably have had some imaging along the way. If they haven't by now, they should, and certainly in a late presentation, or if you're far down the path, I would be doing an MRI scan of the brain. This example here shows, I'm sure most people are familiar with looking at MRI brains, but if they're not, there are 3 black blobs in the middle of this brain. The outer 2, the one on each side, is normal. They're the lateral ventricles, but the one in the middle shouldn't be there. That's a cavum septum pellucidum, which is a post-traumatic phenomenon, but it's also a congenital anomaly. So this would be a structural lesion within a brain that may be making somebody more susceptible to concussive type injuries and persistent symptoms, but equally it may just be a congenital anomaly. So if you find something like this, it would be about doing serial scans perhaps 6 months later or so to see if it's changed, because the traumatic ones tend to progress. This is quite a large one that can be very small, whereas the congenital ones don't really change. I mentioned VOMS assessment there. I found the majority of our athletes who have persistent concussion symptoms often have some vestibular component to it, and within the MDT, having a therapist, a vestibular therapist, is really valuable, and perhaps if in difficult concussions, even having access to 2 or 3, because it's not an exact science, and sometimes a bit like anything where people get a second opinion, where 2 people look at the same problem from a slightly different angle, it can be the second person who manages to make a difference. On that same front, concussion management needs a multidisciplinary team. Certainly I'm not going to be doing vestibular assessments in the same way in my clinic office as a vestibular therapist would be, and certainly in terms of rehabilitation. And similarly, from a cervical spine perspective, yes, I'll be doing my office-based assessment, but the assessments of the physiotherapists that are involved, and the messaging that they're finding and the clinical findings they're finding are really important, for just a different way of looking at the same issue. And these are the kind of 6 domains which I use when I'm treating concussions to think about where the symptoms could lie and where our treatment should be targeted. And this is the Mickey Collins, Anthony Costas model, the UPNC model, which I find valuable from the cognitive and fatigue perspective. It may be that this athlete's so anxious about everything, they're not sleeping properly, they're constantly on the computer. So exploring that sort of area about how good is their sleep through sleep diaries. Are we truly on top of that side of things? As I say, having potential for multiple vestibular therapists if need be, if we don't think we're getting anywhere. The post-traumatic migraine perspective, if somebody's got a predisposition and the symptoms are predominantly head or nausea, being prepared to escalate from first-line treatments to involving neurologists, second-line treatments, and then finally, as I've mentioned, the psychology aspect I think is really important. I've got another athlete at the moment who came to our environment with a significant recent concussion history, really with minimal, all head impacts important, but not big head impacts, was getting significant disabling symptoms. And he did have a bit of an anxiety preponderance, and through involvement of the psychologist and a bit of cognitive behavioral therapy, that side of his problem seems to have disappeared. The cognitive behavioral therapy working on the way that he thinks about his symptoms. So he had anxiety about whether his symptoms were coming on or not, and the CBT helped with that. And so far, 18 months down the line, we don't seem to have any more problems. So I think psychology is really useful. As you get further down the line, once if you really are getting nowhere, and you do have persistent symptoms and nothing has really happened, nothing has really improved things, then this is the point where, once I've revisited with the athlete, start thinking about what options would be available for this player if it was the end of the road. Have we truly explored the MDT? Have they got enough support around them, either pastoral support, lifestyle support for preparing for retirement in terms of their qualifications and their training? Have they got enough family and mental health support around them? And in Scotland, we have this organisation, Brain Health Scotland, which is an organisation that looks at reducing or estimating people's risk of dementia through those 12 modifiers that are listed from the Lancet article, and they have a lot of expertise in terms of supporting people with head injury and a concern about dementia. So perhaps involving an outside charitable organisation, and of course start thinking about who's going to look after them once they do retire. Often we're involved with sports teams or sports organisations, but I'm not their long-term healthcare practitioner. I'm not their GP. And if somebody is retiring from sport, the flow of information to their GP or state health system they're going to go in is really important. So what is our process for transferring those records, and beginning those conversations about, how much did your GP know about this? Do we need to begin to think about who's going to look after you post-retirement? Only once I've done those sort of issues of looking at the patient, the situation, the support available, would I then go back to the patient and see where we are. And if we are at the situation where, from an athlete perspective, they've achieved what they want to do in the sport, they're in their 30s, or whatever age they are, but if they're saying they've achieved what they want to do and they're considering accepting that retirement's the option, only then would I start, with consent, exploring things with the other stakeholders like their employer, to see what the understanding is, the level of understanding is, and what their position is. It may be that this player is the most valuable player in the world to them, and they will give them as long as is necessary, which is an important message to convey to the athlete. Or it may be the club is going to say, well, we're not, from a sport perspective, we're not going to be keeping them on anyway. or maybe in the middle, they may provide a non-sporting role. Well, actually, he's really valuable, and we'd like to move them into coaching. This question always comes up as well from the patient about, what's my risk to my health long term, and it really is impossible to answer, apart from to say the risk of having long-term problems is probably lower than you think, and that's probably because of the human story that's so high profile in the media. A lot of people are concerned, but if you look at in Scotland, dementia is the second biggest diagnosis associated with death on death certificates. It comes in as a 1B, or had dementia. So dementia is very common, but it doesn't necessarily mean you're going to develop dementia in your 40s or 50s because you retire with concussion in your 30s. And through things like Brain Health Scotland and modifying the other modifiers, that's how you can influence your risk. So just a couple of examples. I've said these are fictitious, but they are and they aren't. They are real cases, but I've just changed a lot of the demographics. But the clinical pathway is real. So this is an athlete who was a soccer player in her early 30s, had played international football, but the way football is in the UK, a male international would have made a lot of money. A female international doesn't. It's an amateur sport for the majority, or it was when she was playing, and she may make a little bit of money, but not much. She declared 10 previous concussions to us, which, given that she was in her early 30s at the time, she's probably had some more. But that's a significant concussion history for a sport like football. And she was told to come to see us because of the rise of prominence of concussion, and because she's had 3 concussions in one season, and the people looking after within her team just couldn't get her through GRTP anymore, and the symptoms that she had were beginning to affect her job. So as I've kind of listed, I asked her what her kind of feelings about everything was, and she was frustrated about coming to see us. She wasn't really engaged. She was in a bit of a dispute with those around her, but she was fairly clear that her focus, not on day one, but her focus was she was ready to retire, and her concern was she wanted to be able to hold down a good job and to be able to not struggle with symptoms in the rest of life, other aspects of life. So the other stakeholders in terms of her sport, they weren't that prominent beyond her immediate family. She didn't have an agent, or because it was an amateur sport, and the club, to their credit, had sort of suggested that she get some more help, but they were appreciative that she was an athlete towards the end of her career. The main symptom she had was headache when she did much in the way of screen time, particularly at night, and on exercise. So she was often struggling with getting through GRTP because of the symptoms she had away from exercise, not actually while she was on the bike. With the GRTP, the graduated return to play, you have to be symptom free for the previous 24 hours before you can progress, and it was more away from sport in that 24 hours than the actual 24 hours. So we had a look at her. All her kind of SCAT5 MBES scores, etc., were all very good. We just had this issue of predominantly non-sporting headache and a bit of nausea associated to screen time. We investigated her in terms of scanning her brain. We weren't concerned about her neck, but the investigations were all normal. She saw the MDT, which was a vestibular therapist, and she did have a history of anxiety in the past, and we offered her a psychologist, but she didn't want to engage with that. So again, the athlete making the choices. And across the MDT, we didn't really find anything modifiable. So we involved an external neurologist who, again, didn't come up with a different diagnosis. That bit of, is this diagnosis definitely concussion? They couldn't come up with a different diagnosis than persistent concussion symptoms. And and this is probably slightly unrewarding to say, but she retired. So our focus became about supporting her and transition to the public health system. Through the neurologist, she was given second-line migraine therapies, which again I probably wouldn't be prescribing as a sports physician. As a sports physician, we provided good documentation, and LinkedIn had conversations with her GP and linked her into the longer-term support charities like Brain Health Scotland, and that was it. So she moved on, and our role there was not curing her, but it was more about listening to what she said, making sure she was effectively investigated and was sure of the diagnosis, and passing her on to the state health system, which sounds a bit rewarding, but sometimes that's the way it is with these unsolvable problems. This one's interesting. This was a professional contact sport athlete. Again, declared 7 previous concussions, but because of his age and because of the sport that he did, I suspect he probably had many, many more. I was directly looking after this athlete, and at the beginning of the season, he had what I would call a standard head knock for the sport. Had transient symptoms of not feeling quite right, bit of a headache, dizziness, only for a few hours, one evening, one night. Next morning felt okay. Went through the graduated return to play protocol and the CogSport neurocognitive testing over the following week or 10 days, and no problems at all. Managed to get back to playing and continued for another 8 weeks before we got a second problem. 8 weeks later, he had a much more dramatic and significant incident where he lost consciousness and was very combative with everybody that was trying to help him. He was basically trying to fight everyone, which is probably not a marker of the head injury, probably a marker of the fact he transiently lost his airway when he was unconscious and had a slight hypoxic insult, which, made him combative. This time he was much more symptomatic. I can still see him now. I remember walking in, seeing him head in hands with headaches, looking down, poor eye engagement, really struggling with difficult symptoms. So much so that rather than an MRI, a clinic-based MRI scan a few weeks down the line, on day 2, I sent him to the hospital, the emergency hospital, to get a CT scan just to make sure we hadn't missed a skull fracture or a extradural or something like that. Which we hadn't. It was all normal. And so the language we use in that sort of situation is they're either on protocol for the GRTP or they're off protocol, and that we're just going to stretch it. And so he became off protocol, and again involved vestibular therapy and psychology with him very early. And at 4 weeks, I was happy he'd achieved everything and done enough training wise without being symptomatic that we could let him back, which seemed like a good idea at the time. But unfortunately, the first competitive match that he came back, he had a fairly insidious, a fairly light impact to the head from another player, and was clearly dazed and not right. So he was removed. Unfortunately, that night, his headache and nausea came back, and again he was exactly back where he was before in terms of head in hands at day 3, tearful. So that had been 3 concussions in about 10-12 weeks they'd had, and the last 2 had been fairly dramatic. From a return to play side, the guidelines for the sport would, well, there aren't really guidelines, but the guidelines are make a decision that's more conservative. So I told him and the sport at that time that it would be at least 3 months before we'd be considering to be able to play again. And that 3 months just gave us a good window to think about all the other things we've talked about, exploring things with the stakeholders, exploring things about what he feels about his injury and what his plans are. And actually, because of his age, even though he'd been a top level professional athlete, he had a good plan and had got a good training and qualifications behind him, and even had a job lined up that once he finished playing he could go into. And of course he had a young family, so many of those conversations were with him over those 3 months were around he's worried about the future. The human side of it was driving what he wanted to do. And given the clinical pattern, I advised him that I couldn't say for definite that he would be stuck with permanent symptoms, but I was worried that he'd got a big concussion history, and the threshold for him developing concussions and the severity of his symptoms meant that I thought he shouldn't take contact again and should retire from from competitive contact sport. Again, the luxury of that 3-month window was we could have that discussion with the sport, and we had a good team meeting with people who he valued within the sport. And it was very tearful and it was difficult, but he accepted that it probably wasn't in his best interest, given that his focus was the rest of his life. So although he still stayed within the playing squad, and he did all of the non-contact aspects, the sport used him as a mentor to younger players for the rest of his contract, and we made sure that he had some good psychological and pastoral support, and built good relationships with the state health service for him. Although when he actually retired, unlike the first case I suggested, he didn't have any symptoms at all. He was in normal life. He was functioning completely normally. And a couple of years down the line, he's still completely well and achieving what he wants in terms of his next career and his family. So a more dramatic case, but the luxury there was being able to work closely with the athlete and use those 2 or 3 months to listen to what he wanted to do and try and influence the stakeholders. So in summary, team-based concussion care, those of us that work in week-to-week sport, it's often focusing on return to play. But as soon as concussion becomes difficult, that human story can step forward, and we should shift our focus from return to play to focusing on what the individual wants. There's no one answer for this is the script for what to do, because each individual case will want to do it differently depending on what's important to them. If you've got an effective MDT approach, most cases of concussion can be rehabilitated to a high level of function, although sometimes the timescale that takes may outstrip the timescale of the MDT involvement. So having avenues to pass people on to for longer support once they leave the environment, and that flow of accurate information is really important. With the difficult cases, yes, there has to be a threshold of we're trying to support the athlete, listening to the human story. But if you've got someone who's having persistent symptoms with a decreasing threshold, but they're saying they want to come back, ultimately we do have to make a decision for the safety of the athlete. As you know, as per the second example there, sometimes you do have to just say, look, I don't think this is a good idea. And as I've mentioned, it's important to signpost people and support for the long term, either through the sport, through the sports organisation, or through the state health service, because those people who do have long-term problems with concussion, it's going to go on for much longer than the sports physician or the sports medicine team's involvement. Thank you very much.